primary care physician makes, and how do we have that discussion, and do we have that discussion?
Great. And just start with Jack.
Sure, and having just work with cardiologists, people don't get their hankies out too much with cardiology talk when people talk about maybe cutting the reimbursement there. But in MedPAC, I think was what they did was what Congress asked them to do was if we couldn't find any new money, how would we come up with $300 billion? And they suggested a 17% cut for the specialists, and then holding primary care basically flat for 10 years. So I don't think, and that's a way of dealing with it in a draconian fashion. If you ask Glenn Hackbarth, the chair of MedPAC, was that their ultimate plan? No, but that's what they said they'd have to do if there was going to be no new money to solve this problem. So yes, we probably are going to get a big haircut in the near future. But what I would like to suggest to you is, and Don Berwick has made this point so eloquently, there's another way besides caps on spending and on price controls, which is what Congress knows how to do. The other way is the systematic improvement in quality and efficiency. And as I mentioned earlier, just 10% of the projected spending over the decade in cardiovascular is enough to almost pay off the SGR. So I would tell you, there is another way. And it's one where we could probably, yes, we need to give primary care a boost for sure to make it more attractive. But everybody should be able to get at least what inflation differences are out there. And to get some acknowledgement for producing value, for producing better outcomes at lower costs. If we don't put that kind of incentive out there, it's just human nature. We won't get there as fast. Hospitals and physicians are going to need to figure that out. And we need to have a value agenda and incentives for that, because there'll be fewer per capita admissions, fewer per capita procedures, fewer per capita images, and all of that is going to hurt somebody's bottom line. And we won't get there very fast unless we decide to move in that direction, improve value, quality, and cost. And then there will be some resources left, and we won't be in such a draconian environment.
Any other comments from the panel?
I'll just make two quick comments. One is, one of the things that's worse, the worst thing about SGR is it promotes cynicism by everyone in the system that we're not credible when we talk about constraining costs and dealing with some of these problems. And ironically, if you look at the full range of cost control efforts that have been pursued in Medicare, many of them have been much more effective and credible over a long period of time than SGR. I think the public has a misguided impression based on the annual SGR service that we have. I endorse everything that my colleague said. I do think that there will be a lot of haircuts in the future under ACA or under no ACA. And that's because of the cost trajectory that we're on, and the sooner and the more effective we move on the path to really use all the tools at our disposal to use resources more efficiently, the less severe the haircut will be.
Just one little quick PS on the SGR. Let's not make that our entire focus. We've been focused on it for 10 years. Congress knows it's there. Obviously, it's important, but let's really start thinking about shifting to a quality value agenda, because if we don't, frankly, it's a discussion about a price control mechanism that isn't working. And to have that as the only thing we focus on would be a tragedy.
There's a question up front. Please introduce yourself.
I'm Tom Conley. I practice general internal medicine a few blocks from here for 33 years. I'd like to go to some of the political aspects of one part of the legislation, that is the IPAB, the Independent Payment Advisory Board. It seems like that people, particularly Republicans, but some Democrats, don't like power taken away from them. This is an organization that would be analogous to the Federal Reserve, that a group of 15 appointed by the president who would direct any changes in the way Medicare is paid for. But I wonder if you would comment on that.
Ironically, the IPAB was the brainchild of Senator Rockefeller. You would think that this proposal would come from somebody on the right side of the political spectrum, but it was really from Senator Rockefeller, who looked out and saw Congress micromanaging Medicare year after year and putting in this special favor for this company and that special favor, and just decided, you know, we're not doing a very good job of managing the program, and what we need to do is have some independent experts make some input. Congress still has the ability to come in and change whatever the recommendations are, replace them with something else, but it just, I think he was trying to, and part of the frustration was after what he saw happen to competitive bidding for durable medical equipment, there was a demonstration that showed you could save a lot of money on DME. We had demonstrations showing that nationwide you could save billions of dollars, and yet we kept postponing it or micromanaging it or changing it, and so that was really the reason behind it. You know, I think, and you know, having spent 8 years on Capitol Hill, and I have great respect for Congress, obviously, but look what happened to the debt ceiling last year. Is that really the body that you want when push comes to shove and you're right up against the line of something really tragic happening and Medicare is about to go belly up? Is that really the place you want to be making the decisions? And I think, you know, it's part of the process that brought us the SGR, frankly. SGR, if for those of you who don't remember, was part of the 1997 Balanced Budget Act. It was part of the deficit reduction plan, and it tied physician payments to growth of GDP. And it saved a lot of money, that's right. It was part of a budget deal, but that's not necessarily the best approach to how you want to manage the program. And so the one thing I'll say, because now I'm going on a little too long, is that the ICAP isn't coming into effect for the next 10 years. That we have done enough now that the growth rate is never going to be high enough in Medicare that it's going to trigger a line. So for those who are most afraid of it, we have a little bit of time to try to fix some of these problems and come up with a better way. You know, if your fear really is this independent body, but you know, those of us who worked on it saw that it could be a way to get more intelligent, thoughtful, evidence-based approaches into Medicare in the long run.
Good morning. My name is Don Wynn. I'm from Dayton, Ohio. I have a question for all four people. Liz Fowler, I thank you so much for this wonderful and succinct and thorough rundown of all the provisions that have kicked in or are about to kick in. When I address my colleagues back in Dayton, when I did these Affordable Care Act talks, I always issue this challenge, is if you are a physician and you want to argue against me on these provisions, you have no legs to stand on, because you just cannot argue against the merit of these wonderful provisions. And so I encourage you to use the same argument. Do you have any pull on the Lieutenant Governor of the state of Ohio, Mary Taylor? She's been dragging her feet in terms of setting up these health exchanges. And so what is the White House, what can you do to push that? Because we are basically one of the last 4 or 6 states that have not really done anything. Harold, do you ever get carded anymore? So that's another question. Mr. John Dessa, you don't have to answer this if you don't want to either, but do you have anything to do advising John McCain as to why is it that we can gladly cover or ask the insurance companies to cover for Viagra, and yet he could not answer the question, why is it that contraception and birth controls could not be covered? And last but not least is Dr. Lewin. I did not know that you actually worked at Fox News, is that right? Or is it just a look-alike?
I got too popular over there.
So Liz, maybe you could just say a few words about, in general, what's going on between the White House and
I'm sorry, I have
state exchanges.
the very other thing that I got really excited about driving out here from Dayton is that the one thing I was excited about was to be with all of the people that share my beliefs systems. But the other thing is I was very excited about is the rebate is that for the first time in the history of the health insurance industries, is that there's an estimate of about $1 billion that is going to be returned or rebate or sent back to the consumers. Is that true? And what can we do to push back against these pushback efforts from these insurance companies that are trying to drag their feet and argue against the rebate?
Well, on the rebates, let me just say that those were the estimates when the final rule was published. Now, health insurance companies have done a lot, I think, to change some of their spending and some of their premiums, and so the ultimate amount might not be that much. We'll know later this summer, early fall, what the rebates are, but we know that from early data, we know that there will be some rebates. I just don't know exactly what that is. To your question about Ohio, no, there's nothing we can do, but I will say, and this should be encouraging, we have background conversations going on with all 50 states. That wasn't always the case. There were, for a while there were a couple holdouts that we just didn't have any relationship with at all. We are now engaged in behind-the-scenes discussions with all states. So, whether they get there at the end of the day or whether the federal government is going to end up needing to at least be the one to jumpstart. But we did say that states, if they change their mind or they don't get there in time, can come in at a later date. So I think that even if you're not there right at the start, you can come in later. And then let me end by saying I want to do something a little bit unorthodox about your first point. I'm going to give everyone my email address. And that is because when you're out there talking to people and you say, you know what, if only I had a few talking points, or what's the answer to this question, or I hear a lot of people saying this, and you're just looking for where can you go for information. If you can't find it on healthcare.gov, or hhs.gov, or whitehouse.gov, send me an email and ask me, and I'll try my best to respond. But it's E for Elizabeth, E Fowler, E-F-O-W-L-E-R, at who.eop.gov. And I offer that sincerely. It's E Fowler at who.eop.gov. Because I think people need help in answering some of the questions and responding to some of the critics out there. And so when you need information and you're in a bind or something, I'm happy to try to help.
Thanks.
Thank you.
There's a question over here.
That's a brave move, Liz, to give out your email address. I can tell you she is responsive to a few exchanges, and I can also corroborate what she was saying about the states, even the Republican states, the most diehard Republican states, while they have to appear to be completely anti, and they're participating in the lawsuits, and from media coverage, you would expect they're doing nothing. We also know that behind the scenes they're having discussions and conversations about what would we need to do to set up an exchange. So I think that's constructive. I'm not going to address the contraception issue, but let me just say something about what Jack shared earlier, because I think he's right. And to me, it's not so much about do you repeal one law and replace it with another. To me, it's about calibration. Okay? And there are 1,000, probably 10,000 decisions you can make with this structure of this law that, guess what, if you have a Democratic administration, they're going to calibrate it a little to the left, surprise. And if Republicans were in charge, they would calibrate it to the right. And by that I mean the various flexibility and the types of insurance coverage, or to what income level, the federal poverty level you provide a tax subsidy. There are thousands of questions that Liz and her colleagues tried to struggle through during the legislative process that are about calibration. And I really appreciated the point you made about that.
Is there a question over here?
My name is Dr. Murthy from Miami. I'm a family practitioner, practicing there for about 30 years. This is a specific question for Dr. Fowler. In addition to the universal healthcare access, what we are all proposing through ACA, but also see patients, in addition to getting the universal healthcare, they should be able to get universal access to all the physicians. Creation of these networks by each individual companies are not only restricting the physicians to have a easy access by all the patients, but also they are penalizing the patients who would like to go and see the physician of their choice. using these networks, insurance companies are segregating one group of physicians against the other and restricting the patients to go and see the physician of their child. If they do go, either they have to pay a very high deductible, which is ill affordable, and beats the purpose of the universal healthcare access. So I was just wondering, is there any way we can eliminate these networks, which is designed to restrict the physician's performance and also restrict the patient's access? Thank you.
Well, it's a really good question, and I think the answer goes back to the design of health reform in the first place. I mean, I think once you make a decision to build on the current system, which is, a public, part of it's public and part of it's private, the side that's private uses networks. And I think what we try to do in the final rules in setting up exchanges is to let states use the network adequacy standards that they have. So there is a floor. You do have to provide adequate networks for your patients. That's not to say that every physician is going to be part of it. But, have we taken a single payer approach? It might have been a different story, but I think just starting out with something that builds on what we have today is going to lend itself to that sort of structure. If there are access problems, I mean, I think, and this goes on to the calibration process. If it turns out that there isn't adequate access, that's an issue that needs to be addressed and it needs to be changed. I mean, there should be adequate physicians. People shouldn't have long waiting lists. We've heard from Dr. Emanuel this morning that in Massachusetts it wasn't necessarily a problem, it's more of a redistribution issue. Those are things we're just going to have to see. And in some states there might be issues, and in some states there might not be issues. But it's going to be part of the process. We just need to make sure that over time we're doing an adequate job of making sure that people have access. There is also one of the Patient's Bill of Rights that I didn't mention. There is a requirement that plans have to provide choice of primary care physician and pediatrician, and the ability to see an OBGYN without a referral. So there are we get to some of those pieces, but whether or not that's enough and whether or not we need to think more about it is, we'll see. But thank you, that's a good question.
Question in the middle.
Michael Lewin, I'm an internist primary care here in Washington. I appreciate all the comments of the speakers, starting with Emanuel. I appreciate all the comments of the speakers, starting with Emanuel. And it seems there's a fairly repetitive theme that this is an evolutionary process. And it's going to take time. And talking with physicians, I often talk about the legislative process, evolution, and mention the recurrent laryngeal nerve. Because as physicians, we all understand that if we were at the beginning to design, we'd have the left nerve go directly to our larynx rather than move under the aorta and come back up. But eventually, over time, it worked. If you looked at every major piece of social legislation, starting with Social Security, the implementation of Medicare, Medicare Part D, or other social changes, Brown versus Board of Education, it is an evolutionary process. And I think that all of us here need to appreciate that it's going to take time and there are incremental steps that as we go forward. I think secondly, we as physicians, particularly in this room, often feel that we need to be defending the ACA. And I think we don't need to be defending the ACA, we need to be explaining the ACA. All of us understand that there are problems in the ACA, things that were included that we don't need, and things that were omitted that we do need. But that's part of the political process. And in dealing with groups, whether it's the public, members of the legislative process, or physicians, we all need to make that point. With respect to the physician who raised the question about his colleagues at Durham, we need to reach out to physicians who are frightened, anxious, who are not here, because they don't understand two things. One, that nothing is set in stone, and they have an opportunity to come forward and participate in this process. And I think many of us here in this room have not really turned towards our colleagues who have reservations, uncertainties, and fearful. And we need to make a determined effort to reach out to those people. In talking with physicians, when you say, does anyone think the current system works? People agree about that. Anyone thinks that insurance companies are acting in the interest of patients or physicians? There's agreement there. Raise the issue of tort reform. Raise the issue, finally, of healthcare expenditures. Every physician group that I've dealt with agrees that at least 20 to 25% of healthcare provided unnecessary, inappropriate, ineffective, unsafe. I mean, so there are lots of opportunities. And Dr. Lewin's comment that the way in which we can improve the quality of the care that we provide will account for many of the issues, including reimbursement. I mean, there are all these opportunities, and I think that we as physicians need not feel defensive. And I want to just congratulate and say how much I appreciate all the comments that each one of you have made.
So the session is coming to an end. I maybe thought I would take that last point and broaden it out with one last question, and maybe all four of you can comment. And I think it started with Harold's point, which is if we start with this idea of a moral imperative, and we can all agree that there's a moral imperative to achieve some of these goals. And then if we go through Liz's list of all the things that are in the ACA, and if we can all agree that the ACA achieves a lot of these goals, or will achieve a lot of these goals over the next several years, then what do we do to get everyone to start seeing those first 2 points and the fact that the ACA has come a long way? And I'm curious to hear all of your thoughts on what are the specific areas that doctors, if this room and our colleagues go out to try and push forward this message, what are the specific areas that doctors can have the most impact? And as a second part of that question, how do you build a coalition that goes beyond Doctors of America, of doctors and patients, that can really get these points, these specific impact points amplified? Maybe we could just run down and see what you guys have to say as a closing.
Well, I can start with one point, and that is one thing that's always helpful and that we find very helpful is hearing patient stories. If you have patients that come in, they're covered under the pre-existing condition insurance program, they've got a story that they're willing to share. Sometimes just getting that in the news and just getting it out there is extremely helpful because I think people don't realize even when they are benefiting from a program where that program had come from or how they got to the position that they're in. So I think anything you can do to help educate your patients, and then when you hear a story that is worth sharing, let us know. We actually have a lot of people, and you'll hear from John Carson later this afternoon. He's head of the Office of Public Engagement, and he, first of all, he probably has more good ideas than I'll ever come up with, but his organization, his group within the White House is responsible for collecting all these stories and making sure that people hear about them and really understand how bad the system was and why the change was needed and who's benefiting it and from how. So that's one specific suggestion that I would have.
I would just say that 20 years in this town, politics seems to be a lot about division and whose side are you on, and pick your side. When you come into a congressional office and they know that you're with Doctors for America, and let's say it's a Republican office, their immediate thought is going to be, oh boy, I'm going to get it, right? But when you step up and you approach it in a different manner and you say, we realize you have some concerns about the Affordable Care Act. We want to work with you on how to improve it. The reason I mention this, by the way, is we don't know what's going to happen at the Supreme Court. It could be that it's upheld and we can continue to just maintain our focus on implementation. But what if it doesn't? If in the eventuality that perhaps the mandate, let's say, is struck down, which is the underpinning of so much of this, Congress and this administration is going to be forced back into a room together to work this out, to talk this out. This is going to be hard to do. But you can help with that in the way that you approach these issues. I really believe that. And I guess that would be my suggestion. I'm not a tactic person either, so maybe the gentleman from OPP can give you better advice. I'm talking more about mindset and approach, the way you handle your discussions with your colleagues. Those who are clearly opposed, the way you handle conversations with elected officials, even those who have said they're clearly opposed.
Thanks. I'll just
add to that. I think human stories are essential, and they're starting to accumulate. I mentioned the young adult benefit. There are a lot of people who went, pediatric cancer patients who are now graduating from their pediatric care, and they're now young adults who need chemotherapy or they need whatever they need. A lot of those people are going on to their parents' health plans because of ACA. And I do think we have a very toxic and dysfunctional political system that does not honor the humanity or the intelligence of the individual people that participate in it. And that's just a reality that we all have to deal with on both sides of the aisle. And I think approaching everyone with an openness and a personal respect, even when they're ideological opponents, is very hard to do, but it is very necessary. I think that people do. I do a lot of work in developmental disabilities. One of the nice things about that area is that people on all sides, it is not as polarized. And the Knights of Columbus can work with Planned Parenthood or whatever in a way that doesn't happen too often. And I think we have to find examples where we can work together and build those bridges. I don't know that it's possible on ACA at this point because it is so polarized, and I think it's just some basic strategic decisions that were made, as Fowler mentioned. But I think I think we should approach it in an open spirit.
Ditto to what my three colleagues have said. In addition to that, just remind people about not only are there tens of millions of uninsured people who have coverage who otherwise would be subject to EMTALA or other kinds of, or lack of coverage. But there's hundreds of billions of dollars of new resources coming into healthcare as a result of this act. And people don't seem to understand that because there's so much confusion about the finances. There are hundreds of billions of new dollars coming into care for all the issues, the high risk, the donut hole, the prevention, the under 26, the access general itself, the exchanges. So that's very, very important. And the insurance reform as well. And many physicians don't seem to get that. You need to remind them. Thanks.
Great. Thanks all for your participation. We're going to go to a break now for a few minutes, and I just want to give